Today we're having a webinar on the last chance immunization billing. Claire Pierson has joined us this morning. She will do the first portion of our webinar and discussing contracting, credentialing, issues with the payers, fee schedules, and the no chargeable list. I will be doing the second session portion of the webinar, and I'll be answering questions about billing and coding and other questions that I've gotten over the past 2 years regarding the billing for immunization and their services. I pulled out the most common questions that I've received over this period of time. I know that there's other ones, and hopefully by planting some questions and giving you some answers, it will stimulate your input and your feedback today on other things that may have come up during this time that I've been working with you. We will have, we are still available for you to contact us if there's things that are related to specific items in your health department. Claire will mention it during her presentation that there are some questions that she'll contact you individually on because it may not be applicable to everyone. So with that, I'd like to turn everything over to Claire. And she will be able to start the presentation. Again, thank you so much for your patience.
Good morning, everyone. I really hope that you can hear me. My name is Claire Pierson. I've spoken to you all in these webinars before, so I'm not going to do a long introduction. I represent part of the Department of Health and Mental Hygiene, and for the time being, until somebody else comes along, all of the health departments, and I've also been engaged in the billing and contracting process. So I'm just going to give you a very brief update so that we can catch up on time, and also because I don't want to bog everybody down with too much detail, but we thought it was important for you to know sort of generally where we are in the contracting and fee regulation process. So I'm going to talk to you just very briefly about payer contracting and then the fee schedules, setting regulations, which are in the process of being updated, and just give you a quick status on all of those things, and then I'll turn it over to Chris to do the billing and coding questions. So with the contracting and credentialing for third-party payers, they're sort of broken down into 4 groups: United Healthcare, Care First, the Medicaid MCOs, and then all of the other payers. We're tackling directly United Healthcare and Care First, and then providing guidance on how to contract with the Medicaid MCOs, and then have set up a system if your health department wants to contract with other payers. With regards to United, there's I think as all of you know, there's a statewide contract being set up, and the statewide contract requires sign-on from your individual health departments, and also requires that all of your providers in your health departments become credentialed. Once your providers are credentialed and you have adequately signed on, the health department's adequately signed on to the contract through the State Department of Health and Mental Hygiene, then your health department will be loaded into United's system to become in-network. At this time, we have 18 health departments that have sufficiently credentialed their providers in order to sign on. We have 12 health departments that have actually signed on to the contract and are currently being loaded into United's system. The services covered under the contract are all of your somatic services. They are not behavioral health services. That is a different contract, and I think most of you don't deal with that anyway. Dental services, United has given an option as to whether or not health department can sign on for dental. They encourage you strongly to sign on for dental, but that is not necessary. So the really basic part is somatic services. And that is a statewide contract. There is a specific sign-on and that goes to DHMH, and all of your health officers and administrators should be aware of that. Care First, each contract is being done individually with Care First. Care First has distributed request to contract forms to all of the health departments. Each health department should have gotten that, in some cases twice, because Care First did a round of follow-up. That contract has specific addendums that have been developed with my office, the Department of Health and Mental Hygiene, and Care First, that allow the health department to sign the contract, to sign any contract with CareFirst. When signing a contract, those need to be signed, and an approval process needs to happen with the Secretary of DHMH. But aside from those other two things, which have been documented, your health department should all be okay to go ahead and start contracting with CareFirst, and in fact have probably been invited to do so. The Medicaid MCOs are a little bit different from either CareFirst or United. The Medicaid MCOs are required by the state Medicaid program to sign a specific addendum with a health department or any other state agency with which they may want to contract. So like CareFirst, there's a specific contract addendum to be used for those. The difference being the Medicaid MCOs do not have to contract or have not all agreed to contract with health departments, but in many cases what we're hearing is that they would be interested in doing so. That is going to be an individual process where your health departments will not be invited to contract as they are with CareFirst and United, and will have to do outreach to do so. Within the next week or so, and a memorandum should be going out to all of your health officers describing how to reach out to MCOs, providing contract information, and explaining the Medicaid program's required addendum. With regards to fee regulations, as you all probably know, we have been working on a new set of regulations which set fees for the health departments for quite some time now, I'd say over a year. Although the regulations have not been completely finalized and have not been through the notice and comment period, so they have not been finalized and published for comment. But I can tell you that the current plan is to, rather than the cost-setting measures that you all use now and submit to the department annually, they would set rates at 150% of the Medicare fee schedule. And so that would be sort of the biggest change to the fee regulations. And I think that it looks like that amount of charges, or that method for setting charges, is pretty well decided on, although again has not been finalized. The regulations will also incorporate a hardship policy, which is what your departments will be required to do before you can reduce a fee or use a sliding fee scale. It's not a significantly burdensome process and policy, but it will require a couple of steps. There needs to be a policy in place that says that the health departments charge a full charge to everyone that comes through their door unless they have applied some policy that allows them to reduce a fee. So in practice, it may not look very different than what you all are doing right now, but it will be written as policy into the regs. The current policy under consideration is modeled after Indiana's hardship policy, although the hardship policy is currently for the next 2 weeks, will be under review by the health officers and MHO, and so I can't give you any specifics on what that policy will look like at that time. But in terms of a time frame, which I can give you, I believe that the end of July should see us with a finalized policy, which is the last piece to promulgate the regulations. So I anticipate that the regulations will go to AELR for publication and comment sometime in August. And at this point, I think that was sort of the basic overview I wanted to give, and I don't know how to open it up for questions and answers, but I am guessing Chris and folks will do so, and if you all have questions, I'd be happy to answer them now. I know there are some more specific questions with regards to hardship determinations, and I think Chris has planned to include those in her Q&A session, but please feel free to ask me anything that you have at the moment.
If you have a question, please raise your hand on the dashboard that you see on your screen. All you have to do is push the button to raise your hand, and we will unmute you so that you can ask the question to Claire. Okay.
Great. Well, thanks so much for listening, and I guess I'll turn it over to Chris now.
Okay. Thank you, Claire. Okay, I hope everyone can see my screen now. I'm going to start. Again, everybody I think knows who I am from coming out to your health departments or from prior webinars that we've given. And again, I'm going to address some of the questions that you've sent to me. First question is it required that all local health departments bill or charge for immunizations? And the question is yes. According to COMO regulations, health departments are supposed to charge for health services, and they should reflect the full cost of rendering these services. They also, the COMO regulations also say there should be a single charge for each service rendered in each unit, and the methods for determining full cost be uniform among the units. The only exception to this rule is items that are listed on the non-chargeable list. This regulation does not require that the LHDs bill to the payers. It's just saying you must charge. So the FY15 non-chargeable list, which includes for immunization services, only exclude charging for immunization record review, emergency preparedness, which is screening for and administration of immunizations for traditional and other emergency responders during a local or state public health emergency event. Sliding fee scale, question, can the sliding fee scale be applied to privately purchased vaccines? And the answer is yes, for uninsured self-pay patients. Now this would reflect for adult self-pay patients because any pediatric patients that are uninsured would be receiving the VFC vaccine. The sliding fee scale can be applied to both the vaccine and to the administration fee, which was something we were asked before also because they were wondering if it just would apply to the administration fee, but no, it applies to both. Do not apply the sliding fee scale to charges if the patient has insurance, including Medicare, Medicaid, or an MCO. Apply the full fee scale, the full charge for those services after your payers have paid. If the patient has a problem with paying their portion, if there is a portion, then that's when you can look at applying hardship rules, which, like Claire explained, that will be coming out soon for everyone to be able to see and create have their policy for that, to handle those. There's a big concern for most of the health departments that we came out charging patients and not applying the sliding fee scale for those that have insurance, because sometimes insurance doesn't cover every aspect of the immunizations if you're non-participating. So the hardship will address that issue. A vaccine for children. If a vaccine for children vaccine administration fee is billed to Medicaid or a Medicaid MCO organization, do I have to charge uninsured patients a vaccine administration fee? And the answer is yes. But if the uninsured patient is unable to pay the vaccine administration fee, you must administer the vaccine and waive the fee. This is something else that's been very big concern of the local health departments about the patients that aren't covered by Medicaid or an MCO as to whether they have to charge them. Again, kind of repeating what I just said, if somebody cannot afford to pay for the vaccine administration fee for a VFC vaccine, you do not. You can waive the fee. You have to waive the fee, but you have to provide the service. As far as the VFC vaccine is, $23.28 is what you would charge per vaccine. What is the maximum fee that can be charged to an uninsured child for administering the VFC vaccine? And just as I said, up to $23.28 per vaccine can be charged for administering the VFC vaccine to an uninsured child. If the uninsured patient is unable to pay, again, you must waive that fee. And no proof has to be given by the parent. There's a form that I know all the local health departments are giving for screen as part of the protocol for filing for administering VFC vaccines, and they check it off that just they have the inability to pay. This was another question that I received from a health department. When we submit claims using the CPT vaccine administration codes 90471 to 90474 for VFC vaccines given to children with Medicaid or an MCO, our claims are denied, and why? The reason they're denied is because Medicaid does not recognize or reimburse those CPT codes, the administration codes. VFC vaccines must be billed with an SE modifier appended to the vaccine code. How do we bill for Medicaid or Medicaid MCO for VFC vaccines? Bill, again, with the SE modifier, and this is an example what it would look like. 90648, which is a vaccine code with an SE modifier. Here's another 90700 is another vaccine code with the SE modifier. Again, no administration codes. VFC provider agreement. I decided to put this in, so again, to remind you, this is what is part of your agreement with providing VFC vaccines. I will not charge a vaccine administration fee for non-Medicaid federal vaccine eligible child that exceeds $23.28, and that's the Maryland rate. Each state has a different rate that they've determined that they would charge for the administration fee with the VFC vaccine. And as of this date, 2328 still applies. Last year, it was upped, it retro back until from January 2013, and that rate still remains through 2014. I will not deny administration of a publicly purchased vaccine to an established patient because the child's parent or guardian or individual of record is unable to pay for the administration fee. And for Medicaid children, I will accept the reimbursement for immunization administration set by the state Medicaid agency. Adult Medicaid vaccines. Up until the changes with the ACA and Medicaid expansion, adult vaccines were not covered. With that expansion, adults were covered priorly under PAC, the primary adult care services. So that's one reason why the vaccines weren't covered. They were only covering preventative visits. But at this point, vaccines for adults are covered. Most of them are covered. And this is a website that you can go to check and see if you have any question about the particular vaccine being covered. This will show you by that CPT code if that vaccine is a covered benefit. Does Medicaid cover the administration of adult vaccines? No, they do not reimburse for vaccine administration. So you do not bill the 90471 through the 90474. What you would do with the adult vaccines is they would be purchased privately through your health department, unlike the VFC vaccines that are provided through the state and federal government. Those vaccines, when you bill for those Medicaid for those, you would use the vaccine code and you would bill that, and they would reimburse you for the cost of the vaccine. Privately purchased vaccines. If a child or an adult receives privately purchased vaccines because he or she does not qualify for VFC vaccines and the responsible party doesn't pay for these services, can the health department forward the account to central collection unit? And the answer is yes. Rabies vaccine. On the non-chargeable list, there's no mention of rabies vaccine pre-exposure or post-exposure. According to COMAR, we are required to provide anti-rabies treatment to those who are unable to pay, as well as pre-exposure immunizations for employees of local health departments or individuals who provide rabies control services such as animal control. Please clarify. The department shall provide rabies vaccine according to COMAR regulations free of charge, and the local health officer shall provide for administration of the pre-exposure immunizations against rabies for any employee of the department, a local health department, or another individual who provides rabies control services at the request of the department. Based on the ability to pay schedule developed by the department and circulated to all local health departments, the local health officer may provide rabies pre-exposure immunizations to other individuals who are determined by the public health veterinarian to have high risk or exposure to rabies infection. And this is the link that you can find the COMAR regulations. Medicare immunization coverage. Does Medicare pay for immunizations? Medicare Part B covers the following immunizations and their administration for qualified beneficiaries. As I mentioned in a prior webinar, Medicare Part A is coverage that members have for hospitalization. Medicare Part B is what covers for the medical services of a provider outside of a hospital for medical services. Medicare Part B covers influenza vaccines, and there's no copay and no deductible for that benefit. Pneumococcal vaccines, Medicare cover for all beneficiaries, but only one vaccine at age 25 provides coverage for a lifetime. But if there's some high-risk factors, then Medicare will pay for a second pneumococcal vaccine. There's no co-insurance or co-deductible applied to this, and they do not have to, again, they do not have to meet their deductible to receive this benefit. Hepatitis B are covered by Medicare Part B that are patients that are at high risk or intermediate risk. And that categories would be someone with renal disease, hemophilia, or diabetes. And that is, like I said, covered under Medicare Part B. Co-insurance and co-deductible applies after the co-insurance or co-payment applies after a yearly deductible has been met. So there is some out-of-pocket for that. Medicare immunization coverage beyond Part B may be covered for patients that have Part D. Medicare Part B will cover some other vaccines if there's an exposure, like for tetanus, stepping on a rusty nail. But Medicare Part D will pick up many of the medications that Part B won't. All Part D plans must include commercially available vaccines on their formularies, including the vaccines for shingles. Part D plan will pay for the vaccination itself and for the doctor or healthcare provider who administers the shot. This link will take you right to information about the Medicare Part D benefits and their facts. And additional information on Medicare and Medicare immunizations can be found at this website. Medicare and secondary payers. I'm not sure that everyone understands what a secondary payer is, so I'll explain. If you have a primary insurance and you also carry another insurance through a spouse, or with Medicare, if you have Medicare and you're retired, you may carry a supplemental insurance, which is considered a secondary insurance, which will pick up some of the items that your primary insurance does not cover, like Medicare doesn't cover some of those immunizations or some of the other visits. Because there are limitations on what their coverage is, the secondary payers often will pick that up, and sometimes that's where their drug coverage is also. So the question is, we provide services to patients that have both Medicare and the secondary insurance. The secondary insurance covers services that are not covered by Medicare. We must file a claim with Medicare and receive a denial before we can bill to the secondary payer. Medicare denies the claim. We cannot pay, when they deny the claim, they cannot bill the patient or the secondary insurance. Is there anything that we can do that Medicare denial will allow us to bill the secondary payer or the patient? What happens with Medicare is Medicare will send an EOB, an explanation of benefits, showing that they cannot charge the patient or they cannot charge another insurance because they're saying it's just not covered. They're not going to pay it and you can't bill them. But you can get past that denial if you use a GY modifier when you file the Medicare claim. The GY modifier indicates that the provided service is not covered by Medicare, but it's being reported to Medicare in order to receive a denial. If you file a claim to a secondary payer and they don't have, Medicare says in their EOB that you can't charge the patient or charge the insurance, and they won't pay it, even if it's something that's not covered. So by using the GY modifier, when the EOB comes through, it will show that it's not covered by Medicare, but you are allowed to bill the secondary payer of the patient for those services for that percentage, which is usually 20% of the Medicare allowable. Medicare. Can I bill Medicare for the flu vaccine and administration if I do not charge any other payer or patient for the flu vaccine? The answer is yes. State and local government entities such as public health clinics may bill Medicare for immunizations given to beneficiaries even if they provide immunizations free to all patients regardless of their ability to pay. This is only for the flu vaccine, and it's done usually with the roster billing. Many health departments do not charge flu vaccine for regular patients, but if Medicare, if you have a clinic and you have a lot of Medicare patients in that come through, you definitely would want to roster bill and try to collect and get reimbursement for that, even if you don't charge the other patients that's provided for free. This is unlike what happens with the VFC vaccine. If you bill Medicaid, that you have to bill the patient that are self-pay. This is an override that gives the health departments a little bit more flexibility. And this is the information where you can actually see where I obtained that information from Medicare. And please refer to page 25 when you pull that document up, and that will show you this quote. VFC and 317 vaccines. Question, I was told that we can charge a vaccine administration fee to a client if they don't have insurance and received a VFC or 317 vaccine. ACA guidelines state that there should be no out-of-pocket expenses for preventative services. So why can we charge since vaccines are preventative services? The answer is the ACA guidelines regarding no patient out-of-pocket expenses for preventative services only applies to patients that have a qualifying health plan and receive preventative and immunization services from a participating provider. So the guidelines are for the new insurances that are coming out and not old, I'll get into that more, insurances that are grandfathered in. Any new insurance coming in has to meet certain guidelines that the ACA has put into place. And in the new guidelines, it is about the preventative, not charging a copay or deductibles. But the healthcare law states that health plans offered to individuals in small group markets, both inside and outside the health insurance marketplace, offer essential health benefits. Note that grandfathered plans purchased before the bill was signed into law may not be required to provide these services. Last year, when the requirement came that they had essential health benefits, there were a lot of plans that the insurance payers eliminated, and that caused a lot of problems for patients because when they had to purchase a new health insurance plan that offered these services, the premiums were a lot higher. So they extended the time that these plans could be effective for patients. So in those cases, those patients may have deductibles or copays with preventative services. Billing for RN services. Should we obtain MPI numbers for our RNs and bill immunization services listed the RN as a rendering provider? With immunizations, in most of the clinics, it's just the RN that's doing the work. They're working on standing orders. So, but no, they're not to bill under their own MPI numbers because RNs do not normally get an MPI number. LHD should report the rendering provider as the provider who wrote the standing orders. Claims should not be filed under the provider. The claims should be filed under that provider's MPI number. And usually that will be the health officer, the medical director, or the deputy health officer. Medicaid does not enroll or reimburse RN services unless it's a nurse practitioner. The rendering provider information goes in box 24J on the CMS 1500 claim form. School-based health centers, their MPI number that is billed under is under the school-based health center site number, not under the provider. Unless there's no MPI number for the school base, in that case, it's usually a federally qualified health center or the LHD NPI number that's used. The rendering physician is not used in 24J on the school-based health claims. And I'll explain a little bit more about that on the next slide. School-based health centers, the reason I mention that is because several of the local health departments do administer VFC vaccines at the school-based health centers. So we want to make sure that we're able to capture those charges and get reimbursed for those services. Place of service codes. We are receiving denials from Medicaid for immunization services. We think it's related to the place of service code we use, which is 71 for the local health department. Some payers require us to use the place of service code 11, which is an office code, in order to get paid. Previously, the representative at Medicaid told us to bill 11 instead of 71 to get paid. So they did. We were told to change it to 11, but they will pay us for other immunizations using code 71, so they were unclear. Do you know why the difference and why they won't pay under 71? Is this a legitimate change? I don't want to be fraudulently, but they will pay us with the other code, meaning code 11. The correct code to use is code 71, which is state and local public health clinic, which means in the description is a facility maintained by either the state or local health departments that provide ambulatory primary medical care under the general direction of a physician. But it is acceptable to use place of service code 11, since the LHDs have been instructed by the payers to use this place of service. Some payers and Maryland Medicaid pay LHDs under this place of service. I called the Maryland Medicaid and talked to Molly Mara, and she said yes, the claims come through as place of service 11. I called several of the MCOs, and also their systems, their software systems recognize when claims come through place of service 11. Some of the software is not set up within the payers to recognize place of service 71, and that's the reason why, for the claim, in order for the claim to be processed through their system. So if you've been instructed that it's okay to use place of service 11, and by all means you're able to do that. I would document which payers that you're doing that with. But immunization services provided at school-based health centers must always use place of service 03 when billing for services. According to COMAR, school-based health centers are not required to contract with Medicaid MCOs. The MCOs must reimburse in-network rates for school-based health centers, the full $23.28 administration fee per vaccine. Many of the health departments now, even without contracts with the MCOs, are billing the Medicaid MCOs, which they're perfectly legit. You can bill any payer even if you're out of network. So they're billing the MCOs. Some of them do not get the full reimbursement of $23.28 because they're not participating. They don't have a contract with them. But when it comes to the school-based, the MCOs are required by law to reimburse the full $23.28. Superbill and webinar resources. Do you have any sample superbills for immunizations that can be shared? And the answer is yes, and many of the local health departments have gone onto this website and obtained the superbill. And we do have it in Excel format and also in a PDF. We do encourage you to use the Excel format version, modify it to your health department. We put in all the codes in there, and there may be some vaccine codes that you don't need on your superbill because you don't provide them. So we did one generic one with everything on it, and you can modify it to what your needs are. Another question is, where can we get a copy of the webinars? And again, it's on the website. We will have, this one is being videotaped, and this will appear on the website soon. We have put documents on the website, as we mentioned before, besides the superbill, lots of different PDFs from Medicare and Medicaid on there as resources for you, training resources. We did recently update as of the last couple of days. Went through everything that was on the website. They deleted all the items that are no longer good up to date and put more up to date ones on the website. I do encourage you, when we give you website addresses, that you go in periodically and check, because any information that we put on the DHMH website, any documents, they do get updated on a regular basis. And so anything that we have on there may be outdated, and so you need to check it periodically. Additional information, if you're interested on Obamacare, these are additional websites that you can go to. The first one is talking about benefits. And the second one, the website here listed, is about preventative care. And the third website I mentioned about the grandfathered plan, so that you would further understand what that means. Now I open it up for questions and answers. If anybody has anything, again, just like Claire, you can always contact me. Everybody has my email address, or they can call, and I'll be glad to answer any phones individually with you. But if you have any general questions that you'd like to ask at this time, please do so. We will open up the line here. You can either type in your question, or you can raise your hand. And at this time, I don't see anybody's hands raised. Here's one. And I will see if we can unmute everyone. Is there anyone else that has any questions? Okay, I don't see any questions popping up. I'll give it another minute or so. Okay, a minute. Let me show me. Okay, I do have a question from Nicholas Correa. If you would like to tell me what question you have. Hello? And we do have one question. Will these slides be posted to the website soon? And the answer is yes. I will be working with Robin Decker, and we will get them as soon as we can. The SE modifier, there was a question about that from Jean, and I hope I addressed that when so the SE modifier is used for all BFC vaccines. You bill with the vaccine code, and in the first box on the CMS form beside where you put the vaccine code, there's a place for modifiers. And I hope that answered. And Jean, I'll be glad to talk to you separately if you have any other questions, or even show you a copy of what it looks like. And let's see if there's any other questions that come through. I think that's all the questions. So with that, okay, with that, I think we will end the webinar. And again, I'm so thankful that we finally were able to work out the technical difficulties, and I do appreciate your patience and for attending. And I really hope that the webinar was helpful. And again, please send us any other questions or call us. We'll be glad to answer. Thank you.